When it comes to the business of being born, it seems like it should be rather straightforward. Living in the 21st century, we have experienced a lot of incredible medical advances that have increased the rates of maternal and infant success while reducing rates of life-threatening complications. In doing so, we've also managed to take steps farther away from the natural way of life. Birth has become medicalized in all senses of the word, and we no longer trust a woman's body to properly handle bringing a child into the world. So how exactly have we medicalized birth? Well, many women go into their birth plans knowing that they'll have a hospital birth, probably with a doctor, an epidural, or some other form of pain management, and they give no additional thought to how or where they will give birth. But the assumption is that, like most medical-based birthing techniques, they will be in a bed with their legs in stirrups. In addition to this newfound format of giving birth, some women, when given the option, even choose to pre-plan a cesarean section as an added level of convenience to either themselves or their doctor. Today, the idea of C-section does not seem to concern women as it should. A 2008 study on the risks of cesarean deliveries found that there was a 69% increase in fetal deaths during a cesarean surgery when compared to a normal vaginal delivery. So what steps do we need to take to make a change? Educate. First and foremost, many women are completely unaware of all of their options when it comes to prenatal, postpartum, and labor and delivery care. Preventing cesarean deliveries and increasing the rates of positive experiences during birth should be a #1 priority. So why is there a concern? Well, it's easy to ignore that there's a growing problem when it comes to the business of being born. Over time, our medical technologies have allowed for the justification of unneeded medical interventions and general processes that impact the natural physiological process of birth. As stated by Florence Nightingale, do the sick no harm. This goes both ways. Don't try to fix something that doesn't need fixing, and don't try to stop something before it starts. Because birth is a completely natural process, it is important to let it run its course from beginning to end. Of course, there are always exceptions to that when it comes to life and death situations, but many people are unaware that some of these routine interventions can be placing both mother and baby in a life or death situation. The United States, despite its medical advances, ranks last in the developed world for rates of fetal and maternal mortality, meaning we have the highest rates of fetal and maternal death during birth. A study published by NPR and ProPublica found that more American women are dying of pregnancy-related complications than any other developed country. Only in the US has the rate of women who die been rising consistently over the last decade. There's a hodgepodge of hospital protocols for dealing with potentially fatal complications, allowing for treatable complications to become lethal. This seems backwards, but it's not uncommon. A simple problem is then dealt with what seems like a simple solution that leads to an even bigger problem. Hospitals, including those with intensive care units for newborns, can be woefully unprepared for a maternal emergency. And unfortunately, maternal mortality is higher than infant mortality because the focus of success is on the infant and not the mother. Federal and state funding show only 6% of block grants for maternal and child health actually go to the health of the mothers. Once again, our medical system focuses on the health of the baby, not the mother. And so mothers get lost in all of this, and they tend to be the ones that suffer the most. In the United States, some doctors entering the growing specialty of maternal fetal medicine were able to complete that training without ever spending time in a labor and delivery unit. So this raises more questions about who are the people that are taking care of us. For mothers, are they truly trained to take care of mothers and their babies? There is a serious trend where maternal mortality is rising in the United States at the exact same rate where it is declining in many other developed countries. It is very concerning that a simple or somewhat common procedure can carry the risk of death. These instances are far more likely to occur when a medical intervention that was not initially needed is performed. So here are a list of some of the most commonly used medical interventions during the end of a pregnancy, early stages through end of stages of labor and delivery. Many people are going to be most commonly well known to bed rest. Bed rest is one of the first stages of intervention that is used in a hospital, where, of course, most women tend to give birth. In addition to this, bed rest is then followed by many of these other medical interventions: fetal monitoring, vaginal exams, pain management, all of which are pretty common and routine for most labors. And if you've ever had a baby in our current medical system, if you haven't experienced all of them, you've at least experienced one. They are so common, and while many women have not had any negative experiences with these, they are still dangerous at times. All of these medical interventions build off of one another. So while one does seem harmless, it will lead to something more serious when combined with the others. Going down the line and adding more and more interventions that were originally unnecessary can potentially lead to a cesarean section and other needed emergency medical interventions. While some might think that a cesarean delivery can provide a faster delivery experience, there are many risks that such a surgery may impose on both mother and child. Once again, 69% increase in fetal deaths occur when cesarean surgeries are performed compared to vaginal deliveries. So this is known as the cascade effect. But in order to be able to understand how the cascade effect impacts labor, we must understand labor in general first. Labor is divided into 3 stages: early labor, also known as the latent phase, active labor, and the transition stage. In early labor, the cervix begins to dilate and efface to 3 centimeters. Contractions have begun and last between 30 and 45 seconds. There can be an interval of 5 to 30 minutes between each one. These contractions are rather mild and irregular. While they aren't usually defined as painful, they can be quite uncomfortable. And oftentimes during this stage, some new mothers and repeat mothers can be a little confused as to whether or not they are truly in labor. These very early labor contractions mimic what's also known as Braxton Hicks. Braxton Hicks are contractions that prepare the body for labor that start somewhere between 6 and 8 weeks prior to actual labor. So during early labor, the contractions will become stronger and more regular, but most of the time, women are suggested to relax and wait until this point. Other women have also experienced the breaking of their water during this stage, but that is not necessarily what will happen. Some women don't have their water breaking until the transition stage. The next stage is called active labor. It is much faster than early labor. This stage lasts about 3 to 5 hours, and during this stage the cervix will dilate from 4 to 7 centimeters. The contractions are also longer, about 45 to 60 seconds, and there are only 3 to 5 minutes in between. This is usually the time that a laboring mother should head to her birthing location to avoid a surprise arrival from a baby who's too excited to stay. Finally, the transition stage lasts between 30 minutes and 2 hours. The cervix will dilate fully, usually from 8 to 10 centimeters. Contractions during this stage last 60 to 90 seconds, and there's only a 30-second interval between each one. These contractions are very strong and painful, but they are leading up to the final descent and birth of the baby. It is during these phases that many of the common routine procedures that we saw previously can lead to unnecessary interventions. So, to give an example of how this cascade effect works, you can see that bed rest is the first step. So what is bed rest? Bed rest is typically, in a hospital setting, a form in which a hospital will reduce the movement ability of the mother. While this isn't usually a problem, it can sometimes lead to poor contractions, a slower labor, slower effacement, and a failure for the baby to properly descend through the birth canal. Bed rest is also referred to as the recumbent position, as some may have heard it referred to as before. So in this example, a 30-year-old woman is in the early stage of labor. She's at home and her water has just broken. Her contractions are not very strong and they're irregular and spaced pretty far apart. She calls into her doctor and her doctor has her come in to verify that her water did in fact break. Upon being seen, her doctor verifies that her water has broken, but her contractions are not close enough to warrant a trip to the hospital. He suggests that she go back home and labor at home until her contractions are stronger, closer together, and easier to measure. While at home, he also recommends that she lay down and relax. Because her water has broken, she is on a bit of a clock for what will remain safe for her baby. She returns home and is now on a minor regimented bed rest. The bed rest does not provide the body with an optimal position for stimulating contractions. Of course, she is at home, so she does have a little more leeway in when she can and cannot move. Over the next few hours, her contractions remain irregular. They do not appear to be getting any closer or lasting any longer. Her doctor calls to check in with her, and she gives him an update to where she is. He makes a decision to have her admitted into the hospital. At this point, because her contractions are no longer than they were before, it is becoming crucial that labor progresses, especially since her water broke. Once your water breaks, there is a higher chance that infection can occur or fetal distress will occur because the baby is no longer as safe and secure as it was prior. After arriving to the hospital, the woman's doctor examines her and decides to order a dose of Pitocin. Pitocin is a synthetic hormone that helps stimulate contractions in laboring women. Unfortunately, due to the nature of this drug, the contractions can be extremely painful and cause distress for both mother and child. After giving her Pitocin, her contractions begin to become much stronger and more painful. To make sure that these contractions aren't harming the baby, the nursing staff hook up the woman to a fetal monitoring system. This forces her to remain in a hospital bed, reducing the effectiveness of the Pitocin overall and causing her body an additional bout of pain as she can no longer move through her contractions as her body would prefer. The contractions continue to intensify and the woman requests some pain medication. The nursing staff give her the option of getting an epidural, a form of pain management that is given through the spine. The woman accepts and they begin the process to give her the epidural. It's important to note that an epidural is so strong that it requires a woman to remain on bed rest as they have no ability to move their legs. Fetal monitoring and sometimes oxygen is usually required alongside. Bed rest is needed once again because the individual can no longer feel their lower ligaments. Fetal monitoring will track the contractions and fetal vitals as the mother is usually no longer able to do so herself. But unfortunately, epidurals can prolong labor up to 50% longer. And since in this scenario, the woman's water has broken already, this becomes concerning. Labor needs to be progressing quickly, otherwise fetal distress may set in. So after this woman has received her epidural, she is waiting for her cervix to dilate. After being checked again, she is not dilating quickly enough, but there have been some changes in the baby's heart rate. The doctor orders another dose of Pitocin. Her contractions are further stimulated and her cervix does begin to dilate. After a few hours, the baby begins to show signs of fetal distress. While the woman is close to 10 centimeters, she's not fully there, but the doctor needs to try to get the baby out sooner than later. They place her in the standard stirrup position and tell her to push. Because she cannot feel her contractions, the nursing staff must coach her to push during contractions as the monitors pick them up. After 45 minutes of pushing, the baby has only begun to descend down the birth canal. The heart rate monitors are showing dips in the heart rate and there are signs of meconium, a sign of fetal distress. The doctor decides to try and get the baby out faster by conducting an episiotomy, a procedure where some of the skin near the vaginal opening is cut to help deliver a baby faster. The doctor also uses a vacuum to help suction the baby downward. During this process, the baby's heart rate continues to decline and the vacuum does not seem to be getting the baby down fast enough. To avoid the death of this child and put the mother's health in any further risk, he makes an executive decision to send the woman to the ER for an emergency cesarean. Luckily, the cesarean is successful and the baby is delivered at a healthy weight and there are no further complications. So as you can see, a simple, regular procedure started out and ended in something bigger. It's amazing how something so small can end up placing lives in jeopardy. Minor interventions can lead to major problems, but in such a medically advanced society, these interventions are seen as a way to help rather than hurt. Unfortunately, quite the opposite. So what options are there? There is a lot of research that states that women are not properly educated on their options of birth. But there are 3 major forms of medical care, 3 major birth location options, and 2 birthing styles. Medicated versus non-medicated or natural birth is as simple as stated. Natural birth is going to be the type of birth where a woman objects to any sort of pain medication, pain management, or any drugs like Pitocin, something that might stimulate contractions. A medicated birth is anything where a woman takes any sort of pain management, most commonly an epidural, uses Pitocin to stimulate contractions. Medicated birth is most commonly found in a hospital, and it is very rare that a birth center will have the tools to provide a mother with a medicated birth during labor. Your medical care can also be conducted by a standard OB/GYN, which would just be your regular obstetrician, or a midwife. Midwives are not certified MDs, but they have gone through special training that does give them the authority to make decisions and care for women during prenatal and postpartum periods. Doula support, while it's not a sole form of medical care, is a great way to have additional support during your entire pregnancy process. Doulas are very helpful as far as advocating for oneself and making sure that all the basic questions in between doctor's appointments are answered. When it comes to the 3 birthing locations, home, hospital, and birth center are the most common. Home birth, while an uncommon method, is still utilized in the United States, but only about 1% of women actually have babies at home. When compared to other methods of delivery, a home birth offers the mother and baby the option of delivering in the comfort of their home and removes any sort of medicalized approach, including post-birth testing and or monitoring. Despite not being in a hospital setting, mothers are still able to have a licensed OB as their main physician for prenatal checkups and are often able to have a certified midwife attend their birth. This method of delivery does carry some risk to the infant, despite the risk being low. Infant death is still reported as being up to 3 times higher when giving birth at home in comparison to a hospital or birthing center. It is extremely important for mothers who are choosing this method to ensure that they have had a normal, non-high-risk pregnancy and are not first-time mothers. When it comes to an independent childbirth center or birth center, a lot of women want to have a natural birth in a home-like setting, but still be surrounded by additional people such as nurses who may be able to assist if something goes wrong. Many birth centers are also located either in the same area, across the street from, or down the street from the local hospital. This allows a woman a very short distance to travel in case an emergency medical need arises. Midwives are going to be the attending physician when giving birth at these locations. They also offer limited medical interventions, allowing women to fully embrace a natural birth experience with minimal support needed if something were to occur, such as ultrasound monitoring, IV fluids, oxygen, anesthesia, or local anesthesia, and infant warmers. Another major appealing feature of birth centers is that their use of birthing tubs are available for water, labor, and delivery. Less than 10% of all hospitals within the United States offer this, despite its benefits with shorter labor times, fewer medical interventions, less painful contractions, and improved uterine perfusion. And then the third location is the hospital. Most people will choose a hospital birth. Hospital births are also highly recommended for any woman who's considered a high-risk pregnancy or who is attempting a VBAC, which would be a vaginal birth after a cesarean section. Most hospitals have also moved to a family-centered care option, which allows mother and child to remain bonded through the entire stay of the hospital. Traditionally, hospitals used to remove the baby and place the baby in a nursery to be cared by nursing staff. No longer is that the case, but mothers are remaining in a private room with their child, and our nurses are available to provide assistance as needed at any time during their stay. So how exactly do midwives and doulas change a birth experience? Research has shown that a 9% reduction in the use of pain medication during labor and delivery is common when using these types of assistance during labor. The most common pain medication that is used during labor and delivery is an epidural. Once again, a form of pain medication that works by blocking nerve impulses from the spinal region. While it is not intended to fully remove pain, many women experience a total loss of feeling, which many have reported takes away from the true experience of childbirth. In addition, a 31% reduction in the use of Pitocin, a synthetic version of oxytocin. This is a commonly used drug that helps induce and stimulate contractions in an attempt to avoid lengthy labors. Unfortunately, the use of this during labor increases the risk of fetal distress, a drop in fetal heart rate, infection, and other serious side effects that lead to otherwise unnecessary emergency medical interventions. A 34% reduction in negatively reported birth experiences. This includes negative experiences with support, medical staff, birth expectations and outcomes, pain expectations and outcomes, and postpartum care and recovery. An average of 40 minutes shorter labor times for first-time and experienced laboring mothers. While labor times can vary greatly, the use of synthetic drugs can significantly increase the amount of time a woman's body will experience labor when compared to women who did not use any of these medications. The longer a woman experiences labor, the more likely the labor will end in a cesarean or requiring other medical interventions for the mother and or her child. Lastly, higher rates of successful breastfeeding postpartum with a longer period of time in which a mother chose to continue to breastfeed her child. A study found that women who had doula support during postpartum care, regardless of their socioeconomic status, were more likely to successfully breastfeed for at least the first 6 weeks of their postpartum period. Many of these women continue to breastfeed past the 6-month mark as well. This ultimately strengthens the bond between mother and child and provides the child with all the proper nutrients and natural immunities directly from his or her mother for a stronger start to life. So in general, a doula has 4 major roles. The various supports that doulas provide include informational, emotional, and physical. Being trained professionals, doulas are able to provide resources and referrals for any concerns related to prenatal and postpartum care. Prior to labor, doulas are able to set up a strong communication network between the mother, her partner, and her medical team. This helps support the mother to advocate for herself and make well-informed decisions throughout the entire process. During times of stress, doulas are able to utilize relaxation methods, encouragement, and other forms of emotional support to better create a calm environment, reducing the risks of trauma or emergency interventions due directly to negative effects of stress. Physically, a doula is trained to help ease the pain of birth through methods including positioning and movement, massage, acupressure, hydrotherapy, and more. Postpartum care highly emphasizes a strong start into breastfeeding. Women who receive doula support have reported higher levels of satisfaction with breastfeeding, a better initial latch from their newborn, and longer periods of successful breastfeeding when compared to women who did not have postpartum doula support. Postpartum care is crucial for the success of mother and child bonding and the assistance for mental health challenges that may occur. Most commonly, mild depression is reported in many new mothers, right around 50%. 10% to 20% of new moms will also experience a severe form of depression known as postpartum or perinatal depression, which can interfere with their daily lives. Postpartum psychosis is also rare, but is a serious mental illness that affects 1 in 500 to 1 in 1,000 new mothers. The onset is usually within the first 6 weeks after delivery and may cause the mother to completely lose touch with reality. The depression and anxiety experienced by many women after a miscarriage can continue for years even after the birth of a healthy child, also defined as another form of postpartum psychosis. Having trained support can reduce the risks of all of these ailments and help manage them if they do occur. The process of being born once used to be something that humans relied solely on nature for. There were minimal interventions, low expectations, and costly outcomes. Historically, women were not accustomed to receiving medical care or being overseen from a practitioner during their perinatal labor or delivery periods. Of course, this has now changed, and in recent years, the encouragement to pursue alternative care during pregnancy has become more prevalent throughout the United States health system. While within the United States, the increased medicalization of birth, labor, and delivery has led to a preference for what has been considered a normalized method of perinatal and postpartum care, data has shown that these methods may cause more harm than good. The use of natural-based methods has proven to be far more effective when it comes to the short and long-term successes of a healthy pregnancy, baby, and postpartum period for both mother and child. Understanding and examining the benefits and potential risk factors that such a medicalized system can bring is crucial in determining if natural birth alternatives are necessary in the United States. Furthermore, it's this type of research and understanding that will help push back the repeal for ACA and give back against the major cuts that have been made to statewide insurance companies' coverages such as Medicaid. These services previously helped provide higher levels of care to high-risk, poverty-stricken mothers-to-be, to include preventative care services, maternity care, and free birth control. All of the ways that would reduce the systemic issue that surrounds the death of both mothers and children during labor and delivery.